It is 1 in the morning in StAMPSville. A 26-year-old woman, 32 weeks and 4 days pregnant with her first baby, walks into your emergency department. For 2 days she has had a frontal headache that paracetamol will not touch. Tonight she has started seeing sparkling spots, and there is a dull pain under her right ribs. Her blood pressure is 168/112. Her dipstick shows 1+ of protein. She has driven 180 kilometers from her community, and her auntie is with her.
Stop. Read that blood pressure again. 168/112 after 20 weeks of pregnancy, with a headache, visual disturbance, and epigastric pain. This is severe hypertension, with features of cerebral irritation, in a town with no birthing service, 300 kilometers from the regional hospital, and an aircraft 90 minutes of flight away. If you do not act in the next 30 minutes, the seizure you are trying to prevent may happen on your watch.
Good morning. It is Sunday, the 16th of August. This is StAMPS Daily. 89 days until your CGT StAMPS examination. Phase 1, Foundation. Today we take on one of the highest stakes presentations in rural generalist obstetrics, hypertension in pregnancy, and the pathway from preeclampsia to eclampsia.
And we build it the way the college expects. First, the definitions, because the numbers decide the actions. Then the assessment and the investigations you can actually get at 1 in the morning. Then the drugs, exact doses, exact routes, magnesium sulfate above all. Then the rural reality, no local birthing, a retrieval clock, a young Aboriginal woman far from home. We close with the examiner lens and rapid recall.
One framing point before we start. The guideline that owns this territory is the Society of Obstetric Medicine of Australia and New Zealand Hypertension in Pregnancy Guideline, published in 2023 and current today. When I quote thresholds and doses, that is where they come from, supplemented by state-based eclampsia flowcharts from King Edward Memorial Hospital and Queensland Health.
Definitions first. What number makes a pregnant woman hypertensive?
A systolic of 140 or more, or a diastolic of 90 or more, millimeters of mercury. And the guideline is fussy about confirmation in a way examiners reward you for knowing. Take 3 consecutive readings around 2 minutes apart, and if they are elevated, repeat after at least 4 hours to confirm the diagnosis.
What short circuits that 4-hour confirmation?
Severity. Severe or acute hypertension is a systolic of 160 or more, or a diastolic of 110 or more, confirmed on repeated measures. At that level, you do not wait 4 hours to act. You confirm with a repeat reading over minutes, and you start treatment because that level of blood pressure is associated with maternal stroke, pulmonary edema, and fetal compromise.
So our patient at 168/112 has crossed that line. Now define preeclampsia precisely, because candidates lose marks by being vague here.
Preeclampsia is a multi-system disorder defined by new onset of hypertension after 20 weeks of gestation, accompanied by 1 or more signs of new onset organ involvement. Both halves matter. Hypertension alone after 20 weeks is not preeclampsia until you find or fail to find the organ piece.
Walk me through the organ involvement list, system by system.
Renal involvement, either significant proteinuria, a spot urine protein to creatinine ratio of 30 milligrams per millimole or more, or a serum creatinine above 90 micromoles per liter. Liver involvement, raised transaminases from a normal baseline. Hematological involvement, a platelet count below 150, or features of hemolysis such as low haptoglobin and raised lactate dehydrogenase, or disseminated intravascular coagulation. Neurological involvement, convulsions, which is eclampsia, or features of cerebral irritation, hyperreflexia with sustained clonus, persistent headache, persistent visual disturbance, pulmonary edema, and placental dysfunction, fetal growth restriction with abnormal Dopplers or oligohydramnios.
One of the most examinable sentences in this guideline. Does our patient need proteinuria to carry a diagnosis of preeclampsia?
No. The guideline is explicit. Proteinuria is the most recognized additional feature after hypertension, but it is not mandatory to make the diagnosis. Our patient has 1+ on dipstick, but even with a dry dipstick, severe hypertension plus persistent headache plus visual disturbance plus epigastric pain is preeclampsia with cerebral irritation until proven otherwise. Waiting for quantified protein would be a category error.
And that epigastric pain, why do examiners sit up when a pregnant woman reports pain under the right ribs?
Because it points to the liver, Glisson's capsule stretch, or developing hepatic involvement, and in the spectrum of severe disease it is the herald of the syndrome spelled HELLP, hemolysis, elevated liver enzymes, low platelets. Our patient's combination of epigastric pain and vomiting risk with thrombocytopenia is exactly the cluster that should make me say out loud, I am worried about evolving HELLP alongside preeclampsia.
Give me the classification family, the other siblings of preeclampsia, 1 line each.
Gestational hypertension, new hypertension after 20 weeks with no organ features, which normalizes within 3 months postpartum. Chronic hypertension, present before pregnancy or before 20 weeks. Superimposed preeclampsia, organ features appearing on top of chronic hypertension or pre-existing renal disease. And the mask pair, white coat hypertension, raised in clinic, normal at home, and masked hypertension, the reverse.
A number the guideline attaches to gestational hypertension that changes how tightly you follow these women.
Up to a quarter of women who present with apparent gestational hypertension are actually evolving preeclampsia that has not declared its organ involvement yet, and the earlier the onset, the higher the transition risk. So a diagnosis of gestational hypertension is a license to watch closely, never to relax.
For the focused history, spend 2 minutes on mechanism, because the college rewards a candidate who can explain the disease, not just recite it. Where does preeclampsia begin?
In the placenta, and that single fact explains everything else about tonight. In early pregnancy, the fetal trophoblast should invade the maternal spiral arteries lining the uterus and remodel them from narrow muscular vessels into wide, low-resistance channels. In preeclampsia, that remodeling is incomplete. The placenta ends up perfused under pressure, chronically stressed, and it responds by releasing factors into the maternal circulation.
Which factors, and what do they do once released?
Best characterized are anti-angiogenic, soluble FMs like tyrosine kinase 1, which mops up vascular endothelial growth factor, and soluble endoglin. They tip the balance against the mother's own pro-angiogenic signals, and the result is widespread maternal endothelial dysfunction, leaky, spasming, procoagulant vessels. That is why the kidney drops protein, the liver capsules stretch, platelets get consumed, and the cerebral circulation becomes irritable enough to seize.
Now use the mechanism to answer the question every examiner asks. Why is birth the cure, and why does the danger not end the moment the baby is out?
Because the source of the offending factors is placental tissue, not the baby, so removing the placenta removes the driver. But the endothelium takes days to settle. The anti-angiogenic factors clear slowly, and involution of the placental bed is a process, not a switch. That is why magnesium continues for 24 hours after birth, why postnatal women still seize, and why blood pressure monitoring does not stop at the third stage of labor. The disease is placental in origin and endothelial in expression.
And that is also why the 34-week question is genuinely hard rather than a trick.
Exactly. The treatment of the mother is delivery, and the cost of delivery is prematurity for the baby. Everything in the station is the balancing of those two clocks, maternal endothelium versus fetal lungs, and the balance point moves week by week.
Back to our patient. She is on the bed at 1 in the morning. Take the history. What are the questions that actually change management tonight?
The symptom quartet first, and I ask each one separately. Headache, is it persistent? Is it new? Does it respond to simple analgesia? Visual symptoms, flashing lights, spots, loss of patches of vision, epigastric or right upper quadrant pain, and edema, particularly face and hands, not just ankles. Then fetal movements, reduced movements suggest placental dysfunction. Then bleeding, contractions, leaking fluid, because abruption can ride alongside preeclampsia. Then the background, first pregnancy, body mass index, age, any chronic hypertension, renal disease, diabetes, autoimmune disease, previous preeclampsia, family history in her mother or sisters, and how certain her dating is.
Why does dating certainty matter tonight of all nights?
Because 32 plus 4 today sits just under 34 weeks, and that boundary drives two decisions. First, antenatal corticosteroids for fetal lung maturation, which matter most under 34 weeks. Second, destination. A baby that may be born around 32 to 34 weeks needs a nursery that can receive it, and that shapes whether we retrieve to the regional hospital or the tertiary center.
Allergies and asthma. Why do I ask about those before you touch the drug chart?
Because my first-line intravenous antihypertensive options include labetalol, a beta blocker, which I avoid in asthma and in certain cardiac conduction problems. If she is asthmatic, my acute agent shifts towards hydralazine or oral nifedipine. That one history item rewrites the prescription.
Examination now. Beyond the blood pressure cuff, what are your hands and eyes looking for?
I examine for the neurological warning signs, reflexes at the knees and ankles, looking for hyperreflexia and clonus. I ask her to report visual fields. I check for papilledema only if I am confident in fundoscopy, and I do not make the diagnosis wait on it. I auscultate the lungs for fine crackles, because pulmonary edema is on the organ list and a woman on intravenous fluids is at risk. I check oxygen saturation. I palpate for uterine tenderness or rigidity. Tonic contraction suggests abruption. I assess the fetus heart rate by Doppler or bedside ultrasound, because we have no sonographer at 1 in the morning. And I weigh her, because acute weight gain reflects fluid retention.
Demonstrate the reflex finding that matters. What exactly is sustained clonus, and what does it mean?
With the knee relaxed and the ankle briefly dorsiflexed, clonus is rhythmic beating of the stretch reflex. A couple of beats can be normal in pregnancy. Sustained clonus, beat after beat without fatiguing, is pathological, and it sits on the guidelines list of features of cerebral irritation. Our patient tonight has brisk reflexes with a couple of beats, which I document as borderline, and I recheck at every review, because the trend is the signal.
Say the sentence that ties those findings together for the examiner.
This woman has severe hypertension after 20 weeks with persistent headache, visual disturbance, epigastric pain, and evolving hyperreflexia, which is preeclampsia with features of cerebral irritation, and she is at high risk of eclampsia in the next hours.
That is a diagnosis sentence, and it earns marks because every clause is a guideline criterion. Now the trap question I ask every candidate. Your formal laboratories are couriered 3 times a week. Your platelet count and liver enzymes will not return tonight. Does that delay your management?
Not for a second. The decision to treat severe hypertension and to start magnesium is clinical, made on the blood pressure and the bedside features. The platelets and transaminases will confirm HELLP tomorrow and shape the receiving team's plan for anesthesia and birth, but they do not gate tonight's treatment. In a town without on-site formal labs, preeclampsia with severe features is a bedside diagnosis.
Investigations you can actually obtain at 1 in the morning. List them and say why each one earns its place.
Point of care biochemistry, giving me creatinine and electrolytes tonight, and creatinine above 90 is a renal criterion. A venous or arterial gas, giving glucose, lactate, and acid base, useful if she is deteriorating. Hemoglobin and hematocrit on the point of care machine. A falling hemoglobin with this picture raises hemolysis or abruption. INR at the bedside, my only coagulation window tonight, and a raised INR with low platelets points to disseminated coagulation. Urine dipstick as the screening test 1+ or more keeps preeclampsia squarely in play, and I send a formal protein to creatinine ratio with the next courier. 2 intravenous cannulas before anything else, because she needs drugs, fluids, and bloods. And bedside ultrasound by me for fetal heartbeat and presentation.
Send away and unavailable. Say them plainly so the examiner hears that you know your own town.
Send away with the courier, full blood count for platelets, liver function tests, coagulation profile including fibrinogen, lactate dehydrogenase, haptoglobin, blood film, and the quantitative urine protein. Unavailable tonight, computed tomography and magnetic resonance. So if I suspected a posterior reversible encephalopathy syndrome or a bleed, that suspicion is managed by telephone with a retrieval physician, not by imaging. Angiogenic markers like the soluble FMs like tyrosine kinase to placental growth factor ratio. Useful in metropolitan practice for ruling out preeclampsia in the next 1 to 4 weeks, but not on offer in StAMPSville at 1 a.m., and not required for tonight's decision.
One more preventive thread before we move to drugs because the college loves it. This is her first pregnancy. What should have happened at her first trimester visit, and what does the guideline say about aspirin?
Every woman should have preeclampsia risk assessment early in pregnancy, at minimum from her history and blood pressure. For women at high risk, aspirin 150 mg daily, commenced before 16 weeks, taken at bedtime, and ceased between 34 weeks and birth. And for women with low dietary calcium intake under 1 gram a day, calcium supplementation. In a district where a third of the population is Aboriginal and Torres Strait Islander and remoteness multiplies risk, that first trimester conversation is a genuine life-saving intervention, and after tonight it becomes part of her next pregnancy plan.
Hold that thought, because we return to prevention and to the long-term cardiovascular story after she is stable. Part 2 is where the marks concentrate. The blood pressure is 168/112 and climbing. The drug trolley is open. What exactly do you give, at what dose, by which route, and what is running beside it?
3 things happen in parallel: an intravenous antihypertensive to bring the pressure under 160/110 and keep it there, magnesium sulfate for seizure prophylaxis, and the retrieval call, because the definitive treatment for preeclampsia is birth, and StAMPSville does not deliver babies.
That triple parallel is the spine of the whole station. Take a breath. We will spend part 2 on each limb in turn, with the doses the college expects you to say without hesitation. Then the rural integration, the family, and how you close every loop before the aircraft lands.
We are back. Blood pressure, 168/112, 32 weeks pregnant, headache, visual spots, epigastric pain, brisk reflexes. The aircraft is 90 minutes of flight away and we do not deliver babies in this town. Give me the first 10 minutes.
And I want it as a spoken plan, in order, with names attached. That is what a fellowship answer sounds like. Go.
Minute 0. I say out loud to the nurse in charge, this is severe hypertension in pregnancy. I am treating it as preeclampsia, with cerebral irritation. Activate the obstetric emergency process and call the on-call second doctor. 2 nurses take roles. 1 attaches continuous blood pressure monitoring and repeats the pressure every 10 to 15 minutes, which is the guideline's own instruction during treatment of acute hypertension. The second draws bloods and puts in the second cannula. I take the retrieval call myself, because activation plus flight plus handover realistically means the aircraft lands around 3 hours from now, and that clock started at the moment I suspected the diagnosis.
Before any drug name passes your lips, the question that catches the unprepared: what is the target? Not the direction, the number.
Bring the pressure below 160 systolic and 110 diastolic, and hold it there. The Queensland flowchart phrases the practical aim as 130 to 150 systolic, 80 to 90 diastolic, and above all, avoid maternal hypertension, because a sudden drop starves a placenta already running on reserve. Controlled reduction, never a crash. First agent. She has no asthma, so my choice is intravenous labetalol, 20 mg over about 2 minutes, repeated every 10 to 15 minutes, stepping to 40, then 80, with 80 the maximum per course. If the pressure will not hold, the guidelines practice point is a labetalol infusion, 20 to 160 mg per hour, titrated.
Suppose she is asthmatic. Same blood pressure, wheeze on auscultation. Change my prescription.
Then labetalol is out. I switch to intravenous hydralazine, 5 mg every 20 minutes, maximum 30 mg, or its infusion at 10 to 20 mg per hour. The oral alternative in the guideline is immediate release nifedipine, 10 to 20 mg every 30 minutes to a maximum of 45. All 4 options, labetalol, hydralazine, nifedipine, and intravenous diazoxide, are named in the Society of Obstetric Medicine guideline, and the honest rural answer is that I picked the one my team and I have actually used, because familiarity is part of safety.
One caution: the guideline prints beside nifedipine, which doubles as a monitoring instruction when magnesium is running.
Nifedipine and magnesium sulfate together can produce abrupt hypotension. If I use both, I say so out loud, and the blood pressure monitoring intensifies. It is not a prohibition, it is a watchfulness.
Now the drug this station is truly about: magnesium sulfate, seizure prophylaxis, loading dose, drug dose, route, timing.
Magnesium sulfate, 4 grams intravenously over 20 minutes through a controlled infusion pump, not a hand push. That is the Society of Obstetric Medicine regimen, and it is identical in the King Edward Memorial Hospital and Queensland flowcharts. In StAMPSville, I say to the nurse, load 4 grams over 20 minutes, dedicated line pump, and I stay in the room until it is running.
Maintenance:
1 gram per hour, continuing for 24 hours in total, or from the time of the last seizure if she fits. The infusion runs on a pump through its own line, and no other drug goes through that line.
Who is magnesium for? Is every hypertensive pregnant woman loaded tonight?
The guideline strongly recommends prophylactic magnesium for women at risk of eclampsia, and in practice that is severe preeclampsia, cerebral irritation features, or the decision to deliver. It is also recommended before 30 weeks when preterm birth is threatened. For the baby's brain as much as the mother's, our patient qualifies on every count. A woman with mild gestational hypertension and no features does not automatically get magnesium.
The antidote question: every dose of magnesium you ever give has a companion sitting at the bedside. Name it, dose it, and give the 2 monitoring findings that trigger it.
Calcium gluconate, 1 gram in 10 milliliters, 10%, drawn up and physically in the room, given intravenously over 3 to 10 minutes into a large vein if toxicity hits, with cardiac monitoring. The toxicity signs I chart for are loss of the patellar reflexes, respiratory rate under 12 per minute, falling urine output, under 25 mils an hour, and falling oxygen saturation. Nursing checks reflexes, respiratory rate, and urine output every hour, and the infusion stops and I am called the moment any of those thresholds cross.
Her urine output drifts to 15 mils an hour on the hour of the infusion, and her reflexes disappear. What has happened and what do you do in the next 60 seconds?
Magnesium is renally cleared, and in preeclampsia the kidney can betray you, so she is accumulating. I stop the infusion, I give the calcium gluconate. I check her airway and breathing, saturations and conscious state. I call the retrieval physician to report a magnesium toxicity event, and I do not restart the maintenance without renal function in hand and the obstetric physician's agreement. If her creatinine was already raised, this was foreseeable, and the Queensland flowchart drops the maintenance to 0.5 gram an hour when renal function is impaired.
Now the event we have been circling, she seizes. Full eclampsia in your emergency department. Narrate it.
Left lateral position, airway support, oxygen if saturations are low, and protect her from harm. But the seizure itself usually stops. Magnesium is the treatment, 4 grams over 20 minutes if she was not loaded. Or, if she seizes despite the infusion, a further 2 grams over 5 minutes, which may be repeated. Benzodiazepines only if the seizure is prolonged while magnesium is being prepared. The Queensland flowchart and King Edward both keep diazepam or midazolam in reserve, never as first line. And the moment the seizure ends, the conversation with the retrieval obstetrician changes, because eclampsia moves the birth decision from days to hours.
2 practical eclampsia drills for a small hospital at night. Say them because saying them shows you have actually run one.
Suction, airway equipment, and the second magnesium dose are drawn up and at the bedside before they are needed, and the bed rails are up, the room is cleared, and everyone knows the seizure is coming, which sounds trivial until you have watched a woman aspirate in the cluttered resuscitation bay. We rehearse this quarterly with the nursing team, and tonight that rehearsal pays.
Fluids. The instinct of every new graduate is to run saline wide open. Why is that instinct dangerous here?
Because the preeclamptic capillary leak, plus magnesium plus steroid stress, makes pulmonary edema a real risk, and multiple trials showed aggressive fluids harm. I restrict maintenance to around 80 mL an hour on local protocol, put in an indwelling catheter, chart hourly urine output, and keep strict input-output balance. Crystalloid is for resuscitation indications only, like a bleed or true hypovolemia, not for routine hydration.
The baby at 32 plus 4. 2 fetal considerations now, 1 pharmacological and 1 logistical.
Pharmacological. Antenatal corticosteroids for lung maturation, 2 doses, 24 hours apart, dosed on the receiving obstetric team's protocol, given now because birth within a week is a live possibility, and we are under 34 weeks. Logistical. Destination. A 32 to 34 week baby needs nursery capability, so with the retrieval consultant I weigh the regional hospital 295 kilometers away, against the tertiary center, and the aircraft usually makes that decision with me rather than for me. Magnesium running before 30 weeks would be fetal neuroprotection too, but at 32 and 4 the maternal seizure indication is the one that counts tonight.
The retrieval call itself. Deliver it as you would at 2 a.m.
Doctor speaking. StAMPSville Hospital. I have a 26-year-old primigravida, 32 plus 4 weeks, severe preeclampsia with cerebral irritation, blood pressure 168/112 after labetalol, headache and visual spots for 2 days, epigastric pain, brisk reflexes with clonus, magnesium loaded, infusion running, pressure trending down, fetal heart present, no sonographer tonight, growth unknown, formal labs couriered, results tomorrow. I need obstetric retrieval with neonatal capability, advice on steroid dosing, and a destination decision. Aircraft timing puts wheels up in approximately 90 minutes.
Every element a consultant needs, and it took 40 seconds. Now the human layer. She is Aboriginal, 180 kilometers from home, 1 in the morning, her auntie beside her, and she has just been told she may be flown somewhere she has never been to have her first baby early. What happens in the next 10 minutes that has nothing to do with drugs?
I sit down at eye level. I use plain words, and if language is a barrier, the Aboriginal health worker or liaison officer is woken and on the phone or in the room. I explain 3 things honestly. The blood pressure problem is caused by the placenta. The cure is birthing the baby, and that cannot happen here. So the aircraft is not a punishment, it is the treatment. I ask what she needs for the next 24 hours, who should come, what family business matters, and I ask the auntie the same. I arrange for someone to drive, patient travel assistance, care for children at home, and a phone call to the community clinic so her own health worker knows before the rumor mill does.
And if the weather gods cancel the flight, it is August, dry season, grass fire, smoke, or an unexpected weather cell, what is plan B?
Then we hold the fort for longer and I say that sentence without panic. Continue the infusion, continue blood pressure control, hourly neurological observations, fetal heart checks, and escalation triggers written on the chart. Any seizure, any pressure over 160, falling saturations, reduced fetal movements, bleeding. The retrieval consultant stays on the line as my second brain. 295 kilometers by road is roughly 3 hours in good conditions, and road transfer with a midwife may become the honest conversation. The one thing I do not do is let the plan silently default to waiting.
Postpartum, briefly because the station may end after the birth. 3 commitments you make for the week after.
Magnesium continues for 24 hours after birth or last seizure, because the postnatal ward is where seizures still happen. Blood pressure is monitored, oral agents continued or up-titrated, and non-steroidal anti-inflammatories are avoided for pain. The guideline recommends against their routine use in postpartum preeclampsia until more safety data exist, and she leaves with a cardiovascular story. This episode reclassifies her lifetime risk of hypertension, heart and kidney disease, so the 6-week check includes blood pressure, urine protein, and a plan for the next pregnancy, aspirin 150 before 16 weeks, early screening, and calcium if her diet is short.
Before recall, yesterday's homework. 24 hours ago we ran the febrile toddler with a non-blanching rash. 3 questions. Cold. First, the antibiotic, drug, dose, route.
Ceftriaxone, 50 milligrams per kilogram, maximum 2 grams, intravenously or intramuscularly if access fails, and the intramuscular dose may need splitting in a small child.
Second, the fluid rule in pediatric sepsis.
Boluses of 10 to 20 mL per kilogram, reassess less after every single one. Senior involvement at 20 mils per kilogram. Inotropes considered at 40.
Third, the sentence about a normal blood pressure in a shocked child.
A normal blood pressure is not reassurance, it is compensation. Hypotension is late and pre-terminal, and by the time it falls you are behind.
3 from 3. That is retrieval practice working. Now today's recall, 3 pauses. Answers after each. Pause 1. Severe hypertension in pregnancy is defined as what numbers, and what is your treatment target?
160 systolic or 110 diastolic, confirmed on repeat, and you treat to below those thresholds, practically 130 to 150 over 80 to 90, avoiding hypotension.
Pause 2. Magnesium sulfate regimen, loading and maintenance in one breath.
4 grams over 20 minutes, then 1 gram per hour for 24 hours, or from the last seizure, with calcium gluconate 1 gram at the bedside and reflexes, respiratory rate and urine output charted hourly.
Pause 3. Why must this woman be retrieved? In one sentence a consultant would nod at.
Because the definitive treatment for preeclampsia is birth, and StAMPSville has no birthing service, so every stabilizing action I take is preparation for a delivery that has to happen somewhere else.
The examiner lens on today's topic. The generic answer says, treat the blood pressure and transfer. What does the fellowship answer add?
Exact doses for labetalol, hydralazine, nifedipine and magnesium, and the target they serve. The recognition that proteinuria is not required for the diagnosis. The monitoring bundle while the aircraft is airborne, reflexes, respiratory rate, urine output, pressures every 10 to 15 minutes. The destination logic at 32 weeks. And the human logistics for a young Aboriginal woman separated from country and family, because a plan that ignores her reality is a plan she may refuse.
And the one theme that silently fails candidates in this station more than any drug dose.
Timing. Retrieval is called at the moment of suspicion, not after stabilization, because activation plus flight plus handover is 3 hours, and eclampsia does not wait for tidy paperwork. The drug dose error is forgivable if the clock is right. The clock error is not.
3 things you must say, stamped on the chart before you sign it.
1. Severe hypertension after 20 weeks with cerebral irritation, is preeclampsia until proven otherwise, proteinuria or not. 2. Magnesium 4 grams over 20 minutes, then 1 gram an hour, calcium gluconate drawn up at the bedside. 3. The aircraft was called at the moment of suspicion, because birth, the only cure, happens in another town.
Homework for tomorrow, 88 days out. Read the Society of Obstetric Medicine flowcharts 6.2 and 6.6 until the doses are reflexive, and sketch your own town's eclampsia drill. Who draws up what, who makes which call. Tomorrow we move to mental health crisis in a town with no local psychiatry. Until then, keep your reflexes checked and your clocks honest. This has been StAMPS Daily.
We are independent preparation, not the college, and we do not predict stations. Guidelines change. Verify every dose against the current source in front of you, and practice the scenario at your own pace. See you tomorrow, 88 days out.